bone, but instead the skin has melted it away. So if you were to come to my clinic and I were to say, you have a cholesteatoma and you need an operation, and the patient would say, I don't want an operation, and I would say, you're at risk for brain abscess, meningitis, and death, they usually sign up. So an ear infection, cholesteatoma is a pretty big deal. It's not a common thing for us to have central complications from ear infections, but they do exist, and we need to be aware of them. So this is the attic cholesteatoma again, with the malleus and incus shaded in, and it shows you that in my office I have a picture of an iceberg. So it shows you that the portion of the iceberg that you can see is not as big as the iceberg is, and that there's a large amount of skin debris underneath the portion that you can see, and that large amount of skin debris underneath can be melting away hearing bones, melting away the covering over the facial nerve, melting away the cover over the inner ear, and melting away the cover over the brain. Okay, let's see if we learned anything today. Okay, so we have a 5-year-old that has fatigue, fever, poor appetite. On exam, we have a right red ear with fluid. Sounds like an ear infection, right? Okay. The Weber goes to the left. The morning was so long ago.
Oh, yeah. Sensory neurons. Or there's
Okay.
sensory neurons.
So oftentimes in these things, let's go with what we would expect. If it were otitis media, fluid causes what? What kind of hearing loss? A conductive hearing loss. So conductive hearing loss, if the Weber should go to the right. Okay. So what we know is that she should have a right conductive hearing loss. Okay. But that's not what we get. So we get a left Weber. So we have this is a sensory neural hearing loss on the right. Something is not right. So, you guys got it right. That's good. So something is not right. And what wasn't right was a rhabdomyosarcoma. So just because a 5-year-old comes in with, and you can get one-sided ear infections. You don't have to have laugh when the mommies come in. They're like, another double ear infection. Okay. They don't always have to be double ear infections. They can happen on just one side. But you guys have some very powerful, simple tools that whether you're in Clinton or Stringtown or Oklahoma City, these things can really help. So in my clinic, and we get residents and PA students who come through our clinic. In my clinic, invariably, the two things that they focus on are the fact that we still use these and these. You guys still use those? Yes, every day. Why? Because they're very important. So learn how to use this, and don't forget this, because you might really save somebody's life with a very simple test.
So you said it was sensory neural on the right because of what?
Because of what the chest one.
Oh, because, okay, so,
I know it's because the liver test went left, so this is kind of all right, but what was, did you see what the cause of that?
the cause in this particular child was a Rapid-Meyer sarcoma. So it just means that, you know, things should make sense. And if they don't make sense, then you know, and there's, you know, and, you know, if you send a child to us who you think has something really wrong with them and they don't, we're not gonna call you up and say, don't do that again. We're just gonna say, okay, great, good thinking. You know, because the penalty for missing things is really very high. So, you know, we're gonna say, hey, this is what we said, what we're gonna say is, hey, this is what we found with our audiometric examination, and, you know, your tuning fork was just wrong because it's a 5-year-old, and that's okay. And how do you figure out how to do this with a 5-year-old? If you put the tuning fork up here and it goes to one side, they'll go. Anyway, yes.
Could you have done the Renee test instead of the liver?
Yeah, but that would have been too easy.
Do you start off with the?
I always start with Weber.
Okay.
Yeah.
Oh.
Yeah. No. So. Yeah. So the Rena, the Rena, you know, so it would be the Rena. So if we did the Rena in the right ear, okay. So we put the tuning fork on the mastoid tip. Where does it go?
That'd be how you test the sensory of the right ear.
So it goes to the inner ear, but where does it go
Through the bone.
in this patient?
Oh, so
They don't hear
They don't hear it.
But they don't hear it.
They would hear it. So your skull does not care where you put it. So I can put it here, I can put it here, I can put it on my teeth, I can put it on my chin. Your skull doesn't care. Because your skull is a universal conductor and it's not impeded by anything. So distance is not a factor. So in this patient, we put the tuning fork here. Where would it go?
It would go to the other ear,
Which ear is that?
the left cochlea.
It's going to go to the left ear. Right. So when you do the air conduction, what are they going to say? I don't hear anything.
But yeah, that would have been too
But that would have been too easy, right? So I mean, just you are learning some very valuable things, and just know that, you know, on top of my clinic cabinets are pneumatic otoscopes and tuning forks, because we still use them, and they're very, very valuable. I also have on the other side of my office, you know, 5 AUD PhD audiologists. So you know, we have some advantages that you guys don't have. But still, those, you know, understanding those tuning forks in wherever you're going to end up is very, very critical. Don't forget that part of the neurologic examination. Hearing is very, very important. We'll talk about more hearing stuff tomorrow.
So would this child have conductive hearing loss and sensory hearing loss in the rat if it's fluid filled?
Yes. Yes. The big point here is where's the tumor? No. So yeah, the tumor's on the right, but where is it? It's in the inner ear.
Yeah.
Yeah. So you're like, I mean you know with you know an otoscope and a tuning fork, you figured out that this child has a brain tumor. So this child also had seen their pediatrician for 8 months and been treated with antibiotics over and over and over and over and over and over and over. So in our, you know, in general, we sort of have a 3-month rule. If you're not going to resolved the fluid and your desire to have recurrent acute otitis media within 90 days, you probably have outlived, that diagnosis and need some tubes. So, yes, sir.
For children that are really young, they can't really vocalize hearing loss, what would you do? Like if they can't vocalize that, they can't hear it.
Yeah, tympanogram. Yeah. So the most common thing we see. I do 600-700 cases a year. Vast majority of them have this scenario attached to them. Child has had 6 or 7 ear infections with 6 or 7 courses of antibiotics, and we put tubes in their ears. So we get tympanograms, hearing tests in the courses of those evaluations. So, little kid, we're going to do what we call OAEs, otoacoustic emissions, which is another really cool thing that we can do with expensive equipment that hospitals have, but lots of doctors' offices won't have. We can put a loud sound into the ear. It will pressurize the tympanic membrane, cause a recoil of the ossicular chain, and then a spring back. And if everything is normal, it will send a sound back, and we can pick that up, and that's called an otoacoustic emission. So absence of otoacoustic emissions mean a level of hearing loss. So flat tympanogram, absence of otoacoustic emission, play tympanometry, we can figure out thresholds of hearing loss. Nowadays, children are mandated by state law, if they're born in a hospital, to have newborn hearing screening tests. So they will, through that same system, they will get otoacoustic emissions and auditory brainstem response testing. So what that is we put sound in the ears and record the brain waves, and if you fail that test, then you get to see our office sooner rather than later. So, and that's how we pick up the 1 in 1,000 children who are born with significant sensory hearing loss.
Is it possible to have some fluid in the middle ear and still have mobility of the?
Yes.
So would that child get an antibiotic?
Depending, it just depends on where they are in the cycle. So if you look at the studies that talk about giving children antibiotics, if you put 100 children at the beginning of acute otitis media, you give 50 of them an antibiotic and you observe the other 50 with Tylenol and ibuprofen, the difference to resolution of symptoms, like I feel better and I'm eating and I'm not having as much fever, is about 24 hours between the two groups. So, there's a strong argument that Europe makes that children with acute ear infections should just be given Tylenol, ibuprofen, and observed, and not deplete our ability to use penicillin and amoxicillin as very reliable medications for our acute otitis media. Not every child needs an antibiotic for an acute otitis media. I think that we should be doing probably tubes sooner, because what is an otitis media? It is an infection in a confined space. What's the definition of an infection in a confined space?
It's dangerous, you cannot hear.
Abscess. So what's the drainage, I just said it. What's the drainage of an abscess? What's the treatment of an abscess? Incision and drainage. So we call that maringotomy and tube placement. So in the reasonable parents who would be okay with just observing their child with Tylenol and ibuprofen, in a child who's a little sick but not toxic, hopefully you guys have friends who have babies. And you should tell your friends, I want to see your baby if they're really, really, really sick. Because just looking at a well child and looking at a sick child, like, oh, okay, that is a sick child. So a toxic child is, completely listless, completely just like, Play-Doh. They're just like, ugh, I'm so sick, I just don't care. That child needs antibiotics. But a child who's, kind of running around, a little bit of fever, doing okay when you give them Tylenol and ibuprofen, that's a child who you probably can skate through without an antibiotic.
What if somebody complains about pressure in their ear when they're burping or like ticklish in the back of their throat? Is that a middle ear or an outer ear infection?
It may not be anything. So when you are burping and you sneezing and valsalva-ing, you can push air up into your middle ear space, push out your eardrum, and be very sensitive. For those things, I would just call that normal and just, tell them what it is and not to be concerned about it. High-priced real estate is exquisitely sensitive. Like, we don't like, you guys who can put contacts in your eyes, good for you, I can't. But, high-priced real estate is exquisitely sensitive. Your eye, your cornea, your ear canal, your eardrum. So all of those things, very minute amounts of pressure, can cause lots and lots of pain.
I have a couple questions about the cholesteatoma. Cholesteatoma.
Yes.
The first is, if it's just an outgrowth or a big chunk of skin, how does it eat through the bone?
Very good. What's the largest immunologic organ that you possess?
The skin.
Your skin, right? You do. And what does your skin make to protect you? Lots of really nasty stuff. So all of those skin secretions can melt away bone. So all of the lysozymes that are present in natural skin secretions, all of that stuff that is made by the external auditory canal, that apellosebaceous stuff that protects your ear canal from difficulty, can, in the presence of pressure, melt away the bone. Great question.
And the other one is there anywhere where you could have a cholesteatoma where, I tried, where it's not a danger, where it's just benign, you don't have to worry about it?
No. Yeah. So, I do two things. I do tubes, tonsils, and complex ear surgery. And the complex ear surgery comes from, this eustachian tube dysfunction, cholesteatoma formation world. So it is a ticking time bomb that cholesteatomas of the external ear, middle ear need to be addressed. And sometimes we have to do pretty aggressive things in order to address those things that sacrifice hearing. So, I live in a really simple world. I can make you hear better with a device, and I need to preserve your facial nerve. Everything else, I can make a big open space and clean that space out if you have a cholesteatoma, which gets into some really delicate places, like underneath the facial nerve or in and around the stapes. Okay. Nothing like going long. Yeah, you bet. We'll be back tomorrow.